Adelaide Shoulder and Upper Limb Clinic. Innovative leaders in the diagnosis, treatment and surgery of the shoulder, elbow, wrist and hand in South Australia.
Hi, my name's James McLean and I'm an upper limb surgeon based here in Adelaide. I specialise in shoulder, elbow, wrist and hand disorders. I'm the head of unit of the hand and upper limb clinic at the Royal Adelaide Hospital, Department of Orthopaedics and the University of Adelaide. What we're going to show you today is a shoulder examination aimed at medical student level. The aim is for you to build confidence that you'll be able to do a comprehensive shoulder examination and come up with your own list of differential diagnoses for shoulder conditions at the end of it. So we're going to go through a few steps involved in order to achieve this. The first thing to do is to work out what tools you're going to require in order to do so. There's really only one examination component that you're going to need an examining table for. The rest of the examination can be performed standing. So the first thing to do with all examinations is to introduce yourself to the patient. So, hi Danny, my name's James. Do you mind if I examine your shoulder today?
That's fine.
Thank you. And the second thing to do is to wash your hands with Aqueum. And finally, we prepare by exposing the patient adequately. And in Danny's case, she's already prepared for this. So we can see she's wearing a singlet and we can see her shoulders, elbows, wrists and hands. So the first thing that I do when I examine a patient is look for clues. So I see what they do when they walk into the room. I see how they carry their bag. I see whether or not they're using a walking aid. I see whether or not they're using a sling. In the examination scenario, I'll look around the room. There might be some x-rays up on the wall to give me hints about what the issue is. There might be a sling sitting on a table. So I look around my room to see what's going on first. We then go through the standard look, feel, move special test sequence. However, for the shoulder, what I do is I do look, move, feel special tests. So I switch around feeling and moving. And the reason for that is that the moving component can often give us a good idea about what's going on and give us a shortened examination requirements in order to work out what we're going to be focusing on for that examination. Some of the movements are also painful, so that can help us determine whether or not there's something that we need to skip as part of the examination. So one important component of that is to ask Danny, is there anywhere that's painful for you today? No? That's fantastic, so we can move ahead. So the first thing that we want to do is we want to look from the front. So we ask Danny to face the camera. What we're looking at is for contours. So we're looking from the medial side at the sternoclavicular joint, along the clavicle, the muscle bulk of the trapezius, over to the AC joint, which is sometimes raised if there's pathology within that joint. We look at the front of the deltoid. We look at that position where the humeral head can sit. We look for muscle wasting, for scars, evidence of either pathology or previous injury or surgery. With open surgery, we often have a deltopectoral scar that's relatively long, about 10 centimetres on the front here. So sometimes we'll need to pull back a strap like this in order to see it. Keyhole or arthroscopic holes are often on the front, side and the back. Once we're happy that we've looked at everything that we need to from that side, we'll ask Danny to face the wall, please. What we're doing now is we're looking at the side. So we're looking primarily at the deltoid. We're looking at the position of her spine relative to her plane. We're looking at where her neck sits in relation to the shoulder. So the whole shoulder girdle from the top all the way down to the bottom. We're looking for things like kyphosis lordosis, but also the muscle wasting and how this shoulder sits in relation to the rest of the body. So often pathological related problems of the shoulder can lead to a round-shouldered positioning of that shoulder girdle. And so seeing that from the side is really, really important. Once we're happy that we've identified all of the muscle wasting, looked at the scars, then we ask her to face the other wall. What we're looking at here is similar. So we're looking for primarily muscle wasting, the trapezius at the top, the supraspinatus, which sits in the supraspinatus fossa, the infraspinatus, which sits in the infraspinatus fossa here. We also look in the centre here, medial to the medial border of the scapula, and we're looking at the rhomboids and levator scap to see whether or not there's any associated wasting there. Can I get you to face me now, Danny? So the final thing that we need to look at is the axilla. Sometimes there are scars or other clues as to the pathology there. So do you have any pain if I lift your arm up? No. Just have a look in the axilla, see if there are any scars. Then we move on to movements. So when considering movements of the shoulder, what we want to consider are those movements that are involved. So we're going to be thinking about forward flexion, abduction, external rotation, and then the scapula, retraction and protraction. So in order to examine these things, we want to adequately position Danny. And so ideally we want to be facing one another so that she can copy my movements. So Danny, I'll just get you to face me. The first thing I want you doing is putting your arms by your side, and we're going to test forward flexion. So I'll get you to move your arms up above your head as high as you can get them, and then come back down. This is what we call active forward flexion. So there's a difference between active and passive movements. Active movements are where the patient moves the joint themselves. Passive movement is where the examiner moves it for them. Often there is a difference in the pathological shoulder between active and passive movements. And that difference can give us a hint as to what pathology there may be. So take, for example, Danny, if she was only able to lift her arm to shoulder height. So this one will go up all the way because that one's normal. This one only gets to here. So bring this one down to your side. So if Danny can only get her arm to shoulder height, I'm going to bring it back down. And then I'm going to move it forward and see if I can passively increase that motion. Now the difference between those two movements is important. If the two movements are the same, often that indicates that there is a contracture within the joint. The joint itself is not moving. If there's a difference between the active movement, i.e. the movement that she can achieve, and the movement that I can achieve for her, then often that suggests that there's some problem with the tendon, or there's some problem with the excursion of the tendon or the movement space that it has to move in. And so those, again, will give us clues as to what we're doing. And we apply those same principles to the next examinations as well. So the next examination I'm going to do is abduction. So Danny, if I can get you to put your arms by your side and move it out to the side, all the way up, and then come back down. Similarly to forward flexion, if I'm concerned about a difference between active and passive movement, or if she has no incomplete active movement, then what I want to do is I want to stabilise the scapula. What this does is it then isolates the movement that she's able to achieve to the glenohumeral joint, because there's not going to be any scapulothoracic movement between the scapula at the back and the rib cage at the front. So I'll ask Danny once again with my hand stabilising the scapula to actively move her arm out to the side. And she should be able to get that to 90 degrees. If, for example, she could only get it halfway, so just give us that example, then I'll passively see if I could increase that. If I cannot passively increase that any further, then the active and passive movement equal one another. If I can passively increase her movement to 90, then that difference is once again important and recorded. The next movement that we're going to be doing is external rotation. So in the same position, facing Danny. Danny, can I get you to put your arms by your side? Just get you to lift your elbows up and bend them. With your fingers out straight, just rotate your arms out as far as you can. Similarly, we're looking for a difference between active and passive movement. So similarly, if Danny cannot move any further than, say, 30 degrees, and that's 30 degrees to the frontal plane as measured, then I'll see if I can passively improve that any further. And that's the difference between active and passive. Once again, if they equal one another, then most likely there's a joint contracture. If there's a difference between the two of them, then it's most likely a problem with the tendon or the excursion of that tendon. The next thing that we're going to look at is internal rotation. So internal rotation can actually be measured two ways. The easiest way in patients like Danny who have excellent range is actually to measure it by putting the arm up the back. It's called Apley's scratch test. So the way that we'll do that is, Danny, can I just get you to face that wall for me? And then I put myself in a position where she's able to see what I'm doing so that she can copy the movement. So Danny, just with your good arm, so your left side, can I get you to lift your arm up behind you as far as you can? Yes. And so what we're doing here is we're demonstrating the total range that she's able to achieve on her good arm so that we can then compare it to the other side in a similar manner to what we just did for forward flexion, abduction, and external rotation. So Danny gets to the mid-thoracic spine, which is excellent. That's probably 2 levels more than most patients. Now can you show us with your right hand? And she's almost at the same level. So that is a good comparison between those two things. In this same position, it's an excellent way to test the final 2 movements, which are the movements of the scapula. So the shoulder girdle is also made up by the scapular-thoracic motion. And so what we're looking for is protraction and retraction of the scapula. So what we're going to do is ask Danny, and put your arm down now, Danny. Sorry, I should have said that earlier. We're going to ask her to pull her shoulder blades together. And sometimes we need to demonstrate that, but Danny knows exactly how to do it. What we're looking at here is the degree of motion, the position and height of the scapula in relation to one another, and whether or not there's any obvious wasting of the muscles involved in that movement. In order to test the final motion of the scapula, what we're going to do is we're going to get Danny to walk up to the wall, put her hands up against the wall and push it up against it. This is testing specifically serratus anterior, and we're looking for, once again, very clear unilateral winging on the affected side. So Danny, can I get you to come up to the front here, arms out straight at shoulder height, and just push against it. And what we're looking for here is a prominence on the medial side of both of the scapula. So after completing the movement component of the physical examination, we're going to move on to the feel component. Really what we're feeling for is for pain. So the first thing we want to ask Danny is to remind us whether or not there's anywhere that's painful. Danny, is there anywhere that's painful that you'd like me to avoid? No? Fantastic. So the first thing that we do is position ourselves close to Danny, where we can see her face and see if she's wincing with pain during any of the palpation. We start from medial to lateral. First thing that we start with is the sternoclavicular joint. What we're palpating for is tenderness, crepitus, and any evidence of instability. We then move along the clavicle, doing the same until we get to the acromioclavicular joint. From the acromioclavicular joint is the acromion. We feel the edges of the acromion, and immediately underneath that is the biceps. Now the biceps is sometimes challenging to identify, but is best felt within the bicipital groove. So sometimes we need to flex the elbow up and externally rotate the shoulder with our finger just anterior to the acromion in order to palpate the biceps within the groove. And I move it from a medial to lateral edge until I can feel the 2 ridges of the bicipital groove in order to identify where the biceps should sit. Sometimes, if I'm lucky enough to have a model here, we can see the edge here where that bicep sits, and that's what we're attempting to palpate. What we're looking for similarly is pain. I then move ever so slightly to the medial side of that and feel for the coracoid process, at which there are several origins of tendons and muscles. I then move more laterally, going along the posterior aspect of the acromion, the posterior scapular spine, the supraspinous fossa, the infraspinous fossa, the inferior blade of the scapula, and then a medial blade. And once again, we're looking for anywhere that's tender. So after completing the feel component of the shoulder physical examination, we then move on to special tests, of which there are around 6 main components. The first area that we want to look at is the acromioclavicular joint. The second is the glenohumeral joint, for which there's 2, including frozen shoulder and instability, both kind of opposite pathologies. We then want to think about pathology or special tests related to the rotator cuff that control movements of the shoulder, impingement or movement of that glenohumeral joint complex in the subacromial space, and finally, special tests for the biceps. Special tests for acromioclavicular joint pathology. The main pathology in this joint is arthritis and instability, and fortunately both of those are covered and can be positive with one examination, which is a cross-body abduction. So first thing I need to do is be able to see Danny's face. I lift the arm up in forward flexion to 90 degrees. I then stabilise the scapula with my opposite hand and move the body in an adducted position across the chest. A positive test is pain felt at the joint. I then repeat my test with my finger over the joint. And what I'm looking for and feeling for is crepitus and similarly pain. If the first test is positive and Danny is painful in doing so, I don't then repeat the test. So special tests for glenohumeral joint pathology can be divided into stiff shoulders and loose shoulders. To test for a frozen shoulder or shoulder stiffness, we do an aptly scratch test. So Danny, would you mind facing that wall? Similar to the movement of internal rotation, we see how far up her back Danny can achieve. So can we get you to lift your arm up your back, similar to what you did last time? And then we record the position. Most patients with a frozen shoulder will only be able to achieve internal rotation to around their buttocks or their greater trochanter. The special test for glenohumeral joint instability, the important thing here is to determine what type of instability we're considering. So there can be multi-directional instability or unidirectional instability. So when I examine for instability of the glenohumeral joint, often I want to know whether or not there's generalised ligamentous laxity. To assess for generalised ligamentous laxity, there are 5 Baton tests that we need to perform. We need to demonstrate it for the patient who are often not familiar with these tests. So I'll walk you through with Danny how to perform these special tests. So Danny, with your affected finger, can I get you to bend the little finger back as far as it goes? A positive test is if you can achieve 90 degrees. Danny does not quite achieve 90 degrees, so she's got a negative test, so she gets a test of 0 for that. And then we repeat the test on both sides, so both hands. I'm actually quite flexible on my hand, so I get a positive test for both of those. The next test that we do is we want to see if we can bend the thumb to touch the forearm. And so demonstrating that for Danny, we try and bend it back like so. So Danny gets a negative test, I get a positive test. The third one is that we want to demonstrate whether or not there's hyperextension at the level of the elbow. So making sure that we've got enough room, just put our arms out to the side and make sure that we can achieve full extension at the elbows and see whether or not there's any hyperextension on both sides. We then move on to the lower limb. We ask the patient to face me. Danny, could you face me? What we're going to do is push your knees back as far as they can. And what we're looking for is any recurvatum. So whether or not there's hyperextension at the level of the knees, of which there is none. The final test is to determine whether or not the patient can touch the ground with both hands without bending at the knees. So forward like so. Once I've completed the assessments for generalised ligamentous laxity, then I score out of 9. So each assessment is a score of 1. So a positive score on both sides. So 1, 2, 3, 4, 5, 6, 7, 8, 9 are touching to the ground. A positive generalised ligamentous laxity score is considered 4 or above. I then move on to specific glenohumeral joint special tests for glenohumeral joint instability. So the way that I kind of conceptualise it in my mind is that the ball and socket most commonly come out anterior, inferior or posterior. So the tests that or special tests that we're doing are to determine which direction the glenohumeral joint is unstable in. So the way that we do that is the first test is to determine if there's inferior instability. This is what we call the sulcus test. So the first thing I do is I stabilise the scapula. I then apply a downward pressure on the arm and pull the shoulder. What I'm looking for is a sulcus or an indentation just inferior to the lateral acromion, suggesting that the humeral head is subluxating out of glenohumeral joint. Danny has a negative test. I then move on to a load and shift test. In a similar manner, without moving from the same position and without changing the hold on the humerus, I can then just relax your arm, Danny. I can then grasp the humerus and then load it anteriorly. And so with my left hand, I'm stabilizing the scapula, while with my right hand, I'm pushing forwards. So I'm pushing the humerus anteriorly to see if there's any subluxation of the humeral head at the glenoid. And then I can do the same thing to see whether or not there's any relocation test. And you can palpate and sometimes hear a click as it pops in and out of joint. Danny has a negative anterior load and shift test and a negative posterior load and shift test. Then I move on to posterior shift test, and this is for posterior instability. So similarly, I stabilize the scapula, I lift the arm in forward flexion, I grasp the arm at the level of the elbow, and then I apply posterior force while stabilizing the scapula to see whether or not the humeral head will posteriorly subluxate at the glenoid. And similarly, what we're feeling for is a palpable click as it pops in and out of joint and then relocates. We then move on to an anterior apprehension test. What I'm now going to demonstrate is an apprehension test for anterior instability of the shoulder. In order to do so, what we need is an examining bed like so. What we do is get the patient supine. We then ask Danny to move as close to this side of the bed as possible so that the arm and shoulder are almost hanging off of the table. In order to stabilise the shoulder, what I tend to do is I tend to put a knee just underneath the distal part of her arm. What we're going to do is we're going to put the arm through a series of movements from neutral to extension or external rotation. What we're looking for during that movement is pain or a feeling of instability. So look at Danny's face, put her through a range. If we get to a position, she goes, it feels like it's about to pop out of joint, then we bring it back a little bit. What I then do is I put a posterior force on the proximal humerus, pushing down, and I then try and externally rotate even further. If I can get further, say by 10 to 20 degrees, that would suggest a positive apprehension test. I then let go gently, make sure that she's comfortable before putting her arm back against her side. We then move on to special tests for rotator cuff pathology. So the rotator cuff is made up of 4 tendons. What we want to assess is for the integrity of those tendons and the muscles themselves. So we want to test the power of those muscles independently, and we also want to test for special independent tests that can help us differentiate between those muscle groups. So the first thing that we want to assess is for the power of the supraspinatus, which is the muscle that sits at the top. So what I'll do is I'll get Danny to lift her arm out to the side, get her to point her thumb down to the ground, and ideally we would like our arm in the plane of the scapula. So that's 30 degrees forward of the coronal plane. Often we need to put the patients in that position ourselves. We ask them to hold it there, keep it there, don't let me move it. So hold it there, keep it there, don't let me move it.
Oh,
strong.
Sorry.
That's right. Strong, strong. Fantastic. And sometimes we need to explain a couple of times to exactly what we're trying to achieve. We then move on to assessment of external rotation, which is a combination of infraspinatus and teres minor. So while facing the patient, can I get you to tuck your elbows into the side like this? And then put your arms up like that and ever so slightly out, and you're going to resist me. So hold it there, keep it there, don't let me move it, as strong as you can. Fantastic. We then move on to the special test for subscapularis. So there are 2 main tests for this. One can be done in front of the body, one done behind. The belly test, can I get you to put your hand on your belly like this? Fantastic. I'll get you to pull your arm forward. So what we want to do is we want to position the arm exactly like this. So the wrist is straight, the elbow is bent, and the hand is up against the abdomen. We'll then ask you to hold that position against resistance. So I want you to hold that position and stop me from pulling your hand off the belly. So interestingly, Danny has a positive test. So if she recruits other muscles of her flexors in order to hold that position, then that's a positive test. A negative test is if she can hold that elbow forward of the axillary plane. So hold it there, keep it there, don't let me move it. That's interesting. You do have a positive test. So we'll need to look into that with Danny later on. The next test is the push-off test. So Danny, I'll ask you that you put your hand into the lower back, just here, and then push off. Yeah, perfect. Hold it there, keep it there, don't let me move it. Strong. Pretty good. I then move on to specific tests for isolated muscle groups within the rotator cuff. So earlier on in the examination, when we did the move component, we'll have an idea of whether or not there's a difference between active and passive movement. So really that's when we start to target down onto what muscle groups are involved. So when we're thinking about supraspinatus, what we want to consider is the drop arm test. The way that we assess for that is that we passively move the arm up to here. We ask the patient to hold it in that position. So Danny, can you hold the arm in that position? What we're looking for is whether or not the arm drops down. So if the tendon was grossly torn, the arm would fall down into my hand where I'm ready to catch it. And so that's a positive sign of a massive supraspinatus rotator cuff tear. When we consider the rotator cuff muscles and tendons that are involved in external rotation, such as infraspinatus and teres minor, we need to consider two special tests, those being the lag sign and horn blowers. When we earlier did our assessment of active and passive motion, the lag test is where we'll have a general idea of whether or not there's an external rotation lag. So that's the difference between active and passive movement. When I passively extend the arm further with a lag sign, the arm will flip back to a position that's a lot less. Danny will be unable to hold the arm in this position. So what we ask the patient to do, Danny, can I ask you, can you hold the arm in that position? Fantastic. The arm does not swing back into internal rotation. So that is a negative test. In the scenario where there's incompetence of the external rotators, the arm will reposition itself in a more internally rotated position. The next assessment of the rotator cuff external rotators is the horn blower's sign. So once again, this is a special test with the patient in forward flexion and external rotation. At the level, we ask the patient to hold that position. Can you hold that position, Danny? Fantastic. A positive sign would be an inability to hold that position and the arm falls back into a more internally rotated position, such as so. So in a position like this, the arm goes forward and they're unable to maintain that externally rotated position. I then move on to special tests for shoulder impingement syndrome. Now, shoulder impingement syndrome is primarily where the top of the humerus is impinging into the undersurface of the acromion. And that can be demonstrated on a model quite well, where here the biceps tendon and the rotator cuff are impinging on that lateral edge of the acromion. And that's the movement that we're trying to reproduce when we perform the two important tests for demonstrating impingement. So the first thing to do is stabilise the scapula. I make sure that I can see Danny's face. I then passively move Danny's arm in forward flexion, making sure that I'm noting whether or not any of this is uncomfortable. Danny, is any of this painful? If I get to a position where it's painful or I can feel any crepitus, which is why I have my hand on the anterolateral edge of the acromion, then I stop. I bring the arm back a small amount and then I put it in a slightly different position and see how much impingement there is. That's Neer's test. The second test is called Hawkins' test, and it's very similar. What we do is we actually flex the elbow and we internally rotate the arm slightly. We then move the arm out and external rotation and internal rotation in several different positions. And what we're trying to see is whether or not the greater tuberosity is impinging in different positions of internal external rotation as the greater tuberosity moves underneath the acromion. Often, the patient will have several movements throughout that arc of impingement and crepitus that we can feel and sometimes hear. The final series of special tests for the shoulder is for the biceps. We can break that down into biceps origin tests and biceps tendon tests, the long-headed biceps. This is best demonstrated on the model, where the biceps tendon sits just here. The origin is inside the glenohumeral joint, and the biceps long head sits within the bicipital groove here before it attaches to the main part of the biceps muscle halfway down the arm. So the special tests themselves are to determine if there's a problem at the origin or within the tendon, within the groove itself. So there's 3 tests that we want to assess. The first is called O'Brien's. O'Brien's test for slap biceps pathology is performed standing adjacent to the patient. So I'm standing next to Danny, I can see her face, I can see whether or not she's in any pain. So with the elbow fully extended, I lift the arm up forward to 90 degrees of forward flexion. I adduct 15 degrees and I put maximal internal rotation. So I ask the patient to put the hand in a position like this, like you're emptying out a can. And then I sometimes and often have to reposition the arm in 15 degrees of adduction to make sure that we've got the appropriate starting position. I then ask Danny to hold it there, keep it there, don't let me move it. So hold it there, keep it there, don't let me move it. Strong. Is that painful? No. Without moving your entire arm, can I ask you to turn your hands so your palms facing the ceiling? Fantastic. I want you to hold it there, keep it there, don't let me move it. Is that painful? A positive test would be if there's a difference between the two. So it would be painful to begin with and less painful with the hand facing upwards. We then move on to instability assessments of the long-headed biceps. And this is where the biceps sits within the bicipital groove. So moving from that position, I then move the arm to 15 degrees of forward flexion with the elbow completely extended. Danny, can you hold that position? Hold it there, keep it there, don't let me move it. Strong? Fantastic. Is that painful? No. A positive test would be if she says yes. We then move on to the final test, which is Yergason's test. So Yergason's test is for the same type of pathology, but is less sensitive for differentiating between a slap, origin tear, and instability of the long-headed biceps. So with the elbow at 90 degrees of flexion and the forearm in full supination, we ask the patient to hold it there, keep it there, don't let me move it. But I also try and rotate her forearm into pronation. So she's using her biceps to supinate to try and stop me from pronating her forearm. So I'm trying to extend the elbow at the same time as pronating it. So Danny, hold it there, keep it there, don't let me move it. Strong. Similarly, a positive test would be if Danny has pain with that movement. And that concludes our total shoulder examination. The other 2 things that I would do, depending on the suspected pathology, is a screening of the neck and a neurovascular examination. So hopefully this has given you enough tools to be able to perform a comprehensive shoulder examination with confidence and determine the most common list of differential diagnoses for shoulder conditions. Once you have a framework for a shoulder examination, then you will feel confident about examining more and more patients. The more and more patients that you examine, the better you get at it, and sometimes you can expedite your assessment and make all the steps quicker. So you have a look around the room. Hi Danny, I'm James. Do you mind if I examine your shoulder today? Fantastic. Can't see any splints or aids. Danny, can I just get you to face me? Just looking at her shoulder. Can I get you to face the camera? Fantastic. Looking at the shoulder, looking at the neck. Can I get you to face that wall? Fantastic. Can I get you to face me? Can I get you to lift your arms up above your head, all the way up as high as you can get it? Fantastic. Come back down. Lift them out to the side. Fantastic. Come back down. Get you to hold your hands like this and just copy me out to the side. Fantastic. Just get you to face that wall and just try and lift your arm up behind your back as high as you can get it. Fantastic. I'll just get you to face me. I'll actually face the camera. Palpate sternoclavicular joint, AC joint, along the acromion, along the biceps, coracoid, along the back, along the top. Just let me know if any of this is painful. Is that painful at all? No. Just get you to face me. Hold your elbows in. Hold it there, keep it there, don't let me move it as strong as you can. Fantastic. Get you to lift your arms out to the side. Hold it there, keep it there, don't let me move it. Fantastic. I'll get you to put your hand on your tummy for me. Hold it there, keep it there, don't let me move it. Fantastic. I'll get you to put your arm up behind your back. Hold it there, keep it there, don't let me move it. Just lift your arm off your back. Yeah, hold it there, keep it there, don't let me move it. Fantastic. Sulcus sign. Posterior draw. Load and shift. Well, just, can you tell me if any of this is painful? Just relax. That's painful. Hold that position. Hold it there, keep it there, don't let me move it. As strong as you can. Turn your hand all the way over. Hold it there, keep it there, don't let me move it. As strong as you can. Lift your arm down. Hold it there, keep it there, don't let me move it. As strong as you can. Bend your elbow for me. Fantastic. Stop. Hold it there, keep it there, don't let me move it. Fantastic.
This presentation forms part of the Adelaide Shoulder and Upper Limb Clinic's online educational series. If you would like to view more of our online education materials, please visit our website asulc.com.au.